Good afternoon, everybody. My name is Dr. Juwon Alabi. I'm a consultant obstetrician and gynecologist, and I currently work in the Advanced Gynecological Endoscopy Unit at South Shore Women's and Children's Hospital, Lagos, Nigeria. My topic today is talking about laparoscopic surgery in pregnancy, pros and cons. And basically, if you look at these two images, this is exactly what we're talking about. If you ask a lot of women which of this incision they will prefer, most of them will probably choose the one with the minimal access, unlike the longer midline incision. And a lot of it is based on perception of the implication of this on their, on cosmetics really. So when we talk about laparoscopy in pregnancy, what are the indications? Indications can be both maternal or fetal. In terms of the maternal, it could be ovarian cyst, it could be ovarian incidents like torsion, appendicitis, gallbladder related conditions, ectopic pregnancy, and most recently a lot of surgeries are being done laparoscopically in fetal surgery. So this is an article from the Gynecological Surgery Journal, which was written by a guy called Costas, who we trained together, and he looked at he compared laparoscopy and laparotomy for the treatment of ovarian cysts, and his conclusion at that time was that laparoscopy has equitable outcome compared to laparotomy. And I think basically if you look at it as well, if you look at the cyst in this picture and look at the scar, you will understand what I mean. It will take a longer time for this person to heal, and this procedure could have been done laparoscopically. His conclusion was that for non-obstetric surgical operations and intervention, I think the surgeons should consider doing laparoscopic surgery. This is another article that came from the United States in which Dr. Bosse looked at 11 years of laparoscopic surgery in his unit. And also his conclusion was that for laparoscopic surgery in pregnancy, the outcome is comparable to, the maternal and fetal outcome is comparable to open surgery. So what are the changes that happen in pregnancy that we have to think about, which are cardiovascular, which is increased blood volume and cardiac output, GIT, obviously because of the enlarged uterus and the progestogenic effects, there's reduced motility. Obviously that can impact on surgery in terms of bowel movement and also in terms of the effect of the size of the uterus on the surgery itself. There's increased GFR, there's anemia, dilutional anemia, and also white cell count can be slightly increased, and that sometimes that confuses surgeons in thinking that this might be pregnancy or related rather than an infection. Abnormal clotting profile, which obviously leads to increased DVT or VTE in pregnancy-related surgeries. And I mentioned the delayed organ initially. So going back to the indication for non-surgical or non-obstetric abdominal emergencies, appendicitis, cholecystitis, and gallstones-related issues, ovarian cyst incident, especially torsion. The incidence is about 1 to 2 in 1,000 of pregnant women, which is not as high as you would have thought it would be. And if you look at the potential problem that can happen with acute abdomen, generalized peritonitis, maternal sepsis, miscarriage, preterm delivery and preterm labor and delivery, stillbirth, sometimes maternal death. So the question is also, is laparoscopy safe in pregnancy? I think that's really the question. A few years ago, if you ask this question, a lot of surgeons will say, it's not safe. but there have been numerous publications of good outcome for both mother and the baby after laparoscopic surgery. There's a study out of Sweden which looked at 9 years of they looked at the registry for 9 years, and they were able to get a 69 laparoscopic surgery, which covers all the trimester, and all of it, I mean, they compared it to open surgery, and what they said was that there was a slight increment in preterm delivery and neonatal deaths at 168 hours, which is secondary to the prematurity. And there was also another study from Sweden as well, which they looked at 2,181 laparoscopies done before 20 weeks, and they compared it with 1,522 laparotomies. And they noticed that there was no significant difference in IUGR, congenital malformation, stillbirth, neonatal death, and there were no adverse long-term problems seen. What are the benefits of laparoscopic surgery? The benefits are faster recovery, cosmetics, shorter hospital stay, lower rate of infection, early mobilization, and lesser possibility of VTE if ambulated early. But also you've got to think about if the surgery is long as well, this might be negated. What are the risks of laparoscopic surgery in pregnancy? Obviously, one of the things about surgery, general anesthesia in pregnant women, is that there's an increased risk of aspiration into the lungs. There's an increased risk of perforation of the uterus because of the size of the uterus during port placement, especially the primary port. Bleeding can happen because the womb bleeds a bit more, and if care is not taken and being touched, bleeding can start. Excessive carbon dioxide can lead to maternal acidosis, which can lead to fetal hypoxia. And then reduction of fetal-maternal perfusion, which can lead to IUGR, especially this can be associated with maternal hypotension as well, and post-hernia. Also, there's a higher risk of miscarriage in the first trimester and slightly higher IUGR rate in some studies with women that went through laparoscopic surgery in pregnancy. So now let's talk about the anesthesia. There are people that have done laparoscopy with regional anesthesia, but this is mainly, most of the publications are based on general anesthesia. So how do you prevent problems from happening? You have to have had a detailed preoperative assessment where all the comorbidities is picked up and worked on before surgery. The anesthetist needs to be experienced in obstetrics. So endotracheal intubation is the recommendation. Please do not use laryngeal mask. Consider rapid sequence induction to prevent pulmonary aspiration. But it's important to know that most modern anesthetic drugs do not have teratogenic effect when used within the therapeutic dose. So the second thing is pneumoperitoneum. How do you create it? Some people have said that it's better to use Hassans, but you can use Hassans if the uterus is at below maybe 18 weeks. But anything after that, you can still use Hassans, but if you're going to be using the supraumbilical incision or the palmus, then you might want to come back to either the Verus needle or the port that you can use, the endopath. Yes, the endopath, which obviously can help you enter the abdominal cavity with no problems. The pressure you use for your initial insertion or your port, the primary and the secondary, should be between 20 to 25. But when you want to start surgery, you can reduce this to 12 millimeter mercury, and this has been shown by many studies. I quoted Cardiani in 2012, which they used 12 millimeter mercury, and they looked at the effect on fetal-maternal perfusion, and their finding was that at 12 millimeter there was no effect on the fetal-maternal perfusion. Now, I just put this picture to demonstrate what the uterus will look like at this is about 22 weeks, and compared to Palmer's point, and where you will want to put your ancillary ports as well. So, secondary port placement obviously depends on the uterine size, the pathology, and your approach. Obviously, if you're working on the gallbladder, your incision will be slightly different from if you're working on the appendix or you're doing an ovarian cyst. Whether you use a 5 millimeter or a 10 millimeter laparoscope is entirely up to what you have in your institution and your skill level as well. But remember that 10 millimeter will give you a better image, while 5 millimeter will give you better cosmesis, and also the opportunity that you can put the camera, the scope in any of the ports to have better views or different views of your surgery. In terms of the degree of laparoscope, whether you use 0 or you use 30, it also depends on your skill and your equipment. Some people believe that using 30 will allow you to look at the angles, especially if you're doing an ovarian cyst and the cyst is below the uterus. You might be able to see more clearly if you use a 30 degree. But that is usually based on your experience as well. If you're good at 0 degrees, please continue with that. Now, retrieval bag, it's important that if you're doing any surgery that the specimen is potentially dangerous, either with infection or it might be malignant or stuff like that, I think it's important you do your surgery in a bag or contain the specimen in a bag as well when you're bringing it out. The kind of energy, contrary to what people say about monopolar energy being unsafe, it's not true. There are lots of research or retrospective study that shows that it's safe. Bipolar, ultrasound-based energy, they're all safe to use in pregnancy. This is me just showing Hassan's technique. So you open the umbilical, do almost like a cut down, put the trocar, and then secure the trocar because of the feet, so that gas do not leak leak from the side of the ports. So these are bowel retractors. If you can get them, it's good. They help you during the process. They help you take the bowel away and allow you to, sometimes you can also use the second one, the one on my right, for retracting the uterus as well, because it's blunt, and if you have experience at using it, yes, it can be used safely, but it depends on if you have them as well. Now, during surgery, you can advise your anesthetist to put an oral gastric tube for gastric decompression when you're using the Palmer's point. Like I said earlier, I think you have to be careful touching the uterus, a no-touch approach if you must, but touch with a safe equipment rather than a sharp instrument. If you open the fascia for anything more than 10 millimeter, please close it. Some surgeons will continue to use the lateral tilt. They will put something at the back of the uterus on the left side, the back of the patient on the left side, to tilt the patient a bit so that there's the reduced aortic compression. If you have pneumatic compression stockings, please use it for the surgery. As you know, you want to be able to reduce the possibility of DVT as well. So these are examples. These are common. You can get this quite in Lagos. We use this. For your post-op care, antibiotics is advised to reduce the possibility of post-op infection. Good analgesia, adequate rehydration, and measures to prevent nausea and vomiting. Whether you use a drain or not is your choice. And it's important that you also monitor the baby before the surgery, either with scan or Dopplers, and then you do it after the surgery as well. Monitoring intraoperatively is not recommended, so please don't do that. There's no evidence that using routine tocolysis helps, but if you have done surgery and the person start having irritable uterus, you can start them on tocolysis. And there's no need to use anti-D if the woman is resonative, as laparoscopy is not a sensitizing event. But I mean, I want to believe that will be case-on-case basis. If you think that you have maneuvered the uterus as much as you shouldn't have, maybe you can consider that, or even do a test that tells you whether you need to do it or not. Now, corticosteroids for lung maturation, I think, yes, that is advisable if the patient is in the viability age, but you have to think about the risk of maternal sepsis as well, because when you give steroid with somebody that have sepsis, you might push things a bit harder, or you might make the infection a bit worse. This is a guideline from the Society of American Gastrointestinal and Endoscopic Surgeons that anybody might want to lay their hands on. It gives you the evidence for the advice in performing laparoscopy in pregnant women. There's also the Royal College of Obstetricians and Gynecologists in conjunction with the British Society for Gynae-Endoscopy guideline, which is very detailed. I will advise you to have a look at it as well. So in my conclusion, I think that laparoscopy surgery in pregnancy is safe and has same maternal and fetal outcome, even when performed in all trimester compared to open surgery. Due to the uterine size, these procedures can be challenging with major risk, and it's important that adequately trained laparoscopists should carry out this procedure, and if possible, you can strategize and do the surgery in the second trimester. But if you have to do it in the third trimester, I think you have to have the experience to be able to do it in third trimester. If the expertise is lacking and there's no expert skill or no equipment, please do an open surgery when needed. And hopefully at some point, AGs will start collecting this data so that we will stop extrapolating from overseas. Non-urgent surgeries should be postponed till after pregnancy, but if you must do it, like I said, do it in the second trimester where the risks are a bit more controlled compared to the first trimester and the third trimester. And it's also important that with laparoscopy in advanced pregnancy, it's important that a multidisciplinary approach is used. That means the laparoscopist or the gynecologist, the anesthetist, the obstetrician, and the neonatologist are managing the patient together. Thank you very much for listening, and enjoy the rest of the conference. Thank you very much.